Now we will discuss about short stature. Short stature or stunting is the maximum found malnutrition in Asia-Indian children. All of Asia and India, the malnutrition that occurs in height, not in weight. Stunting, that is called stunting. Stunting. Stunting is the highest parameter of malnutrition. What do we mean by malnutrition? We know that all children are breastfed for the first 6 months of life. Often working mothers, they join early, 4th month or 5th month, and breast milk is not available. For some mothers, they carry their babies in the pouch like the kangaroo and they go to office. I have seen them. There, that means in their office, there is a breastfeeding room and you can breastfeed within hours. After 2 to 3 hours, you get a gap break. You can go and feed your baby, look after your baby, and again you can carry the baby, slips off, and you can carry the baby in the pouch. Now, all offices don't give it. All corporate offices do not make it available. But remember that this class of people is only 15% of the Indian population. Most of the Indian population is 85% is under that socio-economic condition. Think about the gardeners, Assamese gardeners who are in the tea gardens. What do? They carry the basket of tea leaves behind and their babies in front. The hands and the legs are out of the pouch, the head is out of the pouch, and the tea leaves are being picked by the mother. Now, the maximum hypothermia which occurs is through the head, through the palms, and through the soles. No socks covering the hand or the feet, and no cap on the head. These are the places of hypothermia. This is the place from where hypothermia occurs. This is the starting of malnutrition. Hypothermia, hypoglycemia in newborns, they are the initially like infant of diabetic mother. Huge baby, 3 or 4 kg baby. Infant of a diabetic mother, IDM that is called, diabetic mother, they are 4 kg and they suffer from hypoglycemia. Prolonged hypoglycemia. Prolonged hypoglycemia causes brain damage. So this will lead to again stunting. And what is stunting? Stunting is a shortening of the height only. It is not of the weight. The baby is getting breastfeeding, continuously breastfed. Breastfeeding initially, those who are asymptomatic in hypoglycemia, asymptomatic babies are given a breastfeed and assessed after 1 hour that the glucose level has it risen or not. 45 milligram per DL or 54 milligram per DL in bigger children, whether it has been corrected by breastfeeding. But breastfeeding does not correct it in truly hypoglycemic children for whom the islet cells, that is the insulin secreting cells, are hypertrophied. And when the mother gets hyperglycemia, that together with the increased insulin causes hypoglycemia. And this hypoglycemia can lead to stunting later on. So it starts right from the newborn period. I told you we measure the supine length and till 2 years of age, then the standing height. Now, what I want to tell you is this short height can be physiological, it can be pathological. Physiological, there are 2 conditions. One is constitutional delay in growth and the other is familial short stature. In familial short stature, the parents and the grandparents are all short. So the baby, initially the baby might lose weight around 2 to 3 years and then it will pick it up by puberty. Now I have to tell you how this is calculated. This is calculated in a growth chart. Now growth charts, initially we used to have CDC growth charts. CDC growth charts means from America you get it. IAP was sitting and sleeping till 2015. 2015, Khadilkar and Khadilkar, 2 brothers in UP, they assessed a lot of school children, about 20 to 40,000 school children in India, and their fresh IAP curves were released. So you should download the CDC growth curve, IAP growth curve, and the Khadilkar growth curve. 3 growth curves should be in front of you, starting right from the newborn period to 18 years. What you plot in the x-axis and what you plot in the y-axis. In the x-axis, you plot the age, that is 0 to 18 years. Initially, you plot it in months, 2 months, 4 months, 6 months, and later you can do it in years, 2 years, 4 years, 6 years, 8 years. And what do you plot in the y-axis? In the y-axis, we plot the weight, height, and BMI. 3 things. And growth charts will be dealt with in a separate video, and you download growth charts from number 1 CDC, WHO, and IAP and Khadilkar 4 charts. What is BMI? In anthropometry, when we measure the head circumference, the chest circumference at the level of the nipples, and the standing height, the sitting height, the crown rump length, the upper segment, lower segment, similarly we see the mid-upper arm circumference. That is, we measure from the acromion process to the olecranon process, and we take out the middle, and with a measuring tape we measure the mid-upper arm circumference. Mid-upper arm circumference is required for SAM children, severely acutely malnourished. That is called SAM children. SAM children, they have their mid-upper arm circumference less than 11.5 centimeters. Along with that, they have a weight for height score less than 3Z score. What do they mean by 3Z score? From 0 to 100 children you make them stand, and the middle children, the child at the middle is 50th centile. Similarly, below, when you come to the shortest child, you get the 3rd percentile, and as you go up, you get the tallest child. But there is a mid-parental height. What is the mid-parental height? The mid-parental height is, again you calculate it by the father's height, mother's height, add it, divide it by 2, add 6.5 in case of boys, 6.5 you subtract in case of girls. And that line on the 18th year, that is 8 centimeters below that and 8 centimeters below it, that point, it is the mid-parental height, MPH. So that has to be reached. In this physiological short stature also, that is reached. So what happens? What is the difference between familial short stature and constitutional delay? Constitutional delay, puberty is delayed. Puberty is delayed. I told you that 8.5 or 9.5 years in girls and boys, that is the age of when puberty starts. It can start earlier in 6 or 7 years in girls. It can start later in boys, that is 10 to 11 years in boys. That initially puberty will be delayed in constitutional delay. There will be a family history of delay. Family history of delay of puberty. That is their fathers, grandfathers or uncles or aunts, they will all suffer from delay in puberty. Family history. And there are 3 heights: bone age, chronological age, height age. What is bone age? Bone age is how we assess. There are Grolic pile. Grolic pile is another 2 non-Indian people. Grolic and Pyle, they constituted a chart. In that chart, Grolic and Pyle, they said that in the wrist, if you take an X-ray of the wrist, these small carpal bones that are there, the lower end of the radial epiphysis, it appears first. Radius, we know 2 bones are there. One is the radius, the thumb side is the radius, and little finger side is the ulna. So radial epiphysis appears earliest at the end of 1 year. After that, 2 carpal bones appear, 3 at the end of 3 years. And then after that, after 4 years, you add 1 carpal bone and you get the ossification age. That is the bone age. That is how we get the bone age. We have to do a straight X-ray of the hand, including the wrist joint, and we can calculate the bone age. That is the bone age. And what is the height age? Height age? Height age is, according to the age, there is a height that will be reached. I told you it was 50 centimeter initially at birth, 75 centimeter at the end of 1 year, 87.5 at the end of the 2 years, and 100 centimeter at the end of 4 years. After that, I said 4 to 6 centimeter per year till puberty starts. After that, in case of both in girls and boys, it will increase by 9 to 10 centimeter per year till puberty is complete. In girls, it is 15 years. In boys, it is 18 years. After 15 years, girls will increase in weight. Similarly, after 18 years, the boys will increase in weight. And SMR staging I've already taught. In a previous video, you will see it. SMR staging is explained over there, so I'm not going into that now. So, what happens in the familial short stature? Familial short stature, the bone age will be equal to the chronological age. Chronological age, what does chronological? I told you bone age and height age. I did not tell you chronological age. Chronological age is what you predict. What you predict. I told you there's a growth chart. In the x-axis, there's the age in years or months, and in the y-axis there is height. So if you plot for a baby, supposing a 4-year-old baby is 90 centimeter. So according to this x-axis, you plot 4, and according to that 4, where it is touching the curve, that is its chronological age. Maybe if it is 90 centimeter, the child may achieve it at 4.5 years. So that is the chronological age. Understood? So familial short stature, bone age is equal to chronological age. And what happens in constitutional delay? Constitutional delay, the bone age is less than the chronological age. Bone age is less. What does that mean? That means that puberty is delayed, I told you. Ossification occurs mainly during puberty. Ossification. That is the ossification to become an adult man or an adult woman, the pelvic ossification, the knee ossification occurs at birth, before birth, at 9 months. That is in a thyroid, in a short stature due to a hypothyroid. If you do an X-ray of the knee joint, you will see there are stippled epiphyses at the lower end of the femur. Stippled epiphyses at the lower end of the femur. That is in utero it has occurred. And so as soon after birth, as you do the TSH at the 3rd day, that is 72 hours when the TSH has its surge, similarly you do a bone age after taking a X-ray of the knee joint. And so you can, if you see a stippled epiphysis, that is called stippling of the epiphysis, T-S-T-I-P-P-L-I-N-G, that is dotted epiphysis. That will tell you that the baby is truly hypothyroid, and eltroxin needs to be given from the 3rd day, 10 to 15 microgram per kg, and you monitor every 3 months. This is a hypothyroid short stitch. So this chart shows the difference between those two things, that is chronic delay and familial short stature. This one single graph is showing the difference. This is in page 47 in Piyush Gupta. You can get this curve. This is undergraduate for Piyush Gupta, but it is very good for postgraduates also. So this is one curve. This is similarly short stature. This is below the MPH, that is I told you the mid parental height, mean parental height. That mean parental height is shown over here in a red arrow, and it's showing two things. That is, no prior height records are available, but corresponding low weight against a low height. This is showing it. That is in this x-axis the age in years is given, and over here you get the kgs. That is you are getting the stature here in centimeters, and you are getting the weight in kgs. So two curves are showing this well below. That is, it is in the height chart also, it is well below 100 centimeter. That is, it's below the 3rd percentile. 3rd percentile is shown over here, and the 97th percentile is also shown. The 50th percentile is, I told you, 0 to 100 children are standing. The middle child is the 50th percentile. So the shortest child, 3rd, that it is showing that the stature is much below that. The red dot is showing that short stature, that is below the 3rd percentile. And the mean parental height is between 157 to 165. It's shown with a red arrow. So that should be reached in constitutional delay or familial short stature. That is not reached here. And similarly in the lower graph, that is weight for age, it is showing. Now after seeing this graph, next what you order is bone age. After seeing this, you order the bone age. That is, take a wrist joint. Usually we take the left wrist joint. We take a AP view. In case of bones, we take a AP view and we see the carpal bones. The lower end of the radius by the end of 1 year, and the two carpal bones by the end of 3 years, and then you add 1 for each year. This is how you do it. This is showing the x-axis, the age in years, and this is showing the height. This is the y-axis in centimeters. This is the 50th centile. You take the father's and the mother's height in centimeter, divided it by 2 and plus minus 6.5. 8 centimeters below and above that is the MPH. This is the MPH shown over here. So this is showing short stature and failure to thrive. The difference. And the other graphs, 2 graphs, I will be giving it in this video itself. You can see it for the familial short stature and the short stature measurement and the constitutional delay in growth. This one is showing constitutional delay in growth and puberty. That is, below the 3rd centile, the curve goes below the 3rd centile and reaches the mid-parental height later on at adolescence. That is at 18 years. Bone age is less than the chronological age. This is the constitutional delay. There will be a family history positive of constitutional delay in growth and puberty, positive in the family, x-axis and y-axis height. This is another one showing familial short stature. The bone age is equal to the chronological age. Over here, there is a early dent, that is over here in the first 3 years or 5 years or 6 years. There is a fall in the weight of the baby, weight and the height of the baby, and the height of the baby goes to the mid-parental height by 18 years of age. Familial short stature, both the parents will be short and most of the grandparents will also be short. Over here, the bone age is equal to the chronological age. Growth hormone, I told you, bone age is less than the height age, that is less than the chronological age. Infantile facies, short and fat, less than the mid-parental height. Growth hormone should be given before puberty, before ossification. IGF-1 and IGF-BP3 is low. Screening test, growth hormone stimulation, less than 10 nanograms per ml. Upper segment and lower segment should always be taken in the sitting position because CRL, that is the crown rump length, is right from the crown, that is from the top of the head to the sitting height. Sitting height means to the end of the coccyx. That is the upper segment, and the lower segment is from the symphysis pubis to the heels. So this you get the lower segment. Upper segment is more than the lower segment in hypothyroidism. So this is a case of celiac disease. Celiac disease, we know it is treated with gluten-free diet. They are all short. And there's one method of diagnosing it, that is the TTG. That is from the intestinal biopsy, you do a TTG. So once you do the TTG and it is positive, you give a gluten-free diet, the height is increasing. It is showing that the red mark is the original height, and after a gluten-free diet, the height is rising to the 3rd percentile. This is a case of celiac disease. So examination shows us clubbing anemia. Similarly, say cystic fibrosis. Cystic fibrosis children are very unfortunate. Very unfortunate, why? I remember when I was in BC Roy Children, my friend Chandrapati Mishra, who was in BHU, Banaras Hindu University, he was in community medicine. His brother was residing in Calcutta. His son was a cystic fibrosis son. That time, sweat chloride test was not done so frequently in Calcutta. Sweat chloride test was done only in Roy and Trivedi, only one place in Roy and Trivedi, and that boy was diagnosed with cystic fibrosis. The baby was admitted in BC Roy Children once or twice with pneumonia, and loose motions. Ultimately, we lost the child. We lost the child because the cephalosporins had not appeared at that time. It was only ampicillin, gentamicin and chloromycetin was available. The higher cephalosporins came years later, that is in the 90s. In the 80s, it was not available. It was only ampicillin. But surprisingly, ampicillin and gentamicin or chloromycetin is still being used in All India Institute of Medical Sciences and BHU or everywhere to decrease resistance, antibiotic resistance. Very surprisingly, they are still using it. But in Bengal, West Bengal, the first antibiotic that we give either ceftriaxone or cefotaxime or this or that or this or that. We always go for higher antibiotic. I don't understand what we gain by that. Gradually, these babies will become resistant to these antibiotics. When they are old, that won't work. Geriatric age group is the group who is going to suffer. Diabetes, all the comorbidities will appear. Diabetes, hypertension, myocardial infarction, everything will appear at that age. And then when you admit the man or the woman, these antibiotics won't work. But surprisingly, All India Institute, we have a branch now in Kollani. I expect that they at least use ampicillin and gentamicin only. That is one thing. This is another cause of short stature. Here you get shortening of the arms only. Rhizomelic shortening it is called. That is the upper part of the arm. That is only this arm is shortened. The forearm is normal. Arm is shortened. Similarly in the legs the femur is shortened and the tibia and fibula is a normal size. You get a flat acetabular fossa. That is the pelvis, the acetabular fossa is flat. So it doesn't enter, the femoral head doesn't enter and slips from the acetabular fossa. So they bend once to this side to put the fossa, to put the head of the femur in, again bends to this side to put the head of the femur in. That is achondroplasia. And one achondroplasia married another achondroplasia and they had an achondroplasia child also in BC Roy children. One 4th class staff. He was suffering from achondroplasia. He married another achondroplasia lady and they had an achondroplastic child also. I will tell you another cystic fibrosis child, my own experience. In Shagurdatto hospital, one baby was brought from Howrah. Father was a Muslim. Father brought the baby, 9-year-old. Female baby. All the residents rang me up, told me a baby has come with severe pneumonia. I told them, is clubbing present? They did not know what is clubbing. What is clubbing is a general survey, I haven't taught it yet. It is there in this general survey. Clubbing is this nail beds and the difference between the nail beds. That if you do this, that is you oppose your index fingers, there should be a diamond-shaped gap. I don't have that gap. Why do you think so? I don't have that gap. Because I am an asthmatic. I already suffer from hypoxia. Any cause of hypoxia will cause clubbing. And that is the first degree of clubbing, that is that diamond-shaped gap goes. And then it becomes just bulbous ends of the fingers. The fingers become bulbous at the ends. And with that baby, I reached, as soon as they told me, it was early in the morning, 8:30. I reached by 9:30. I saw the clubbing and I wanted a bronchoscopy done. Bronchoscopy was not done in Shagurdatto Medical College. I sent the baby to Columbia, Asia. One of our pediatrician brothers, Pallab Chatterjee, he did the bronchoscopy. And as soon as he introduced the bronchoscopy, he rang me and he told me, Madhusmita Di, it is totally viscid. It's a case of cystic fibrosis. I told him I expected it and that is why I sent it to you for bronchoscopy. This is how we diagnose cystic fibrosis. The later you diagnose it in life, the earlier chance of death. There is a sweat chloride test which is now being done in various hospitals. You can do it, not only sweat chloride, you can use a moisture with the moisture, you can cover your hands and expose it to the sun and then see how much sweat is coming, and then you can assess the chloride. It is done in many hospitals now, but it was not done earlier. And when I was in Shagardatto, that is very, few years back, just pre-COVID era, I think 2019, 18 or 19, I saw this baby. And that baby, finally, I lost it because the baby, simultaneously, the baby had tuberculosis. And it was a resistant tuberculosis. DOTS plus regime, she had to have that tuberculosis, anti-tubercular drugs. And she went to her place in Howrah and she's getting her anti-tubercular drugs there. And she will need about 1 year of ATD, DOTS plus regime, which was not there previously in 15 plus children. Now it is rampant because sputum positive father who's getting second line AT drugs will transmit that INH resistance and rifampicin resistance to his son. And nowadays, when we diagnose TB in a child, tissue diagnosis is very important now. Tissue diagnosis is we do CB-NAT of the gastric lavage. CB-NAT may be positive, may not be positive. Sputum negative may be there. But if from the tissue, if we get the tuberculosis, then it is very important that you have to diagnose it in that way for INH resistance and rifampicin resistance. That is done only in the districts, only in Tangra in Calcutta, only that resistance is done. We had our RNTCP training, now it is called NTEP, National Tuberculosis Elimination Program. That center is in Tangra, and that is where we saw the AFBs in the microscope, and we saw the resistance to the INH and the rifampicin being done. Now, how do you differentiate between a pituitary dwarf and a thyroid dwarf? A pituitary dwarf is short and fat. Short and fat. And small penile length. How do you measure the penile length? Like BMI is measured from the 3rd year. Similarly, penile length is measured from the 3rd year. Penile length is taken from the symphysis pubis and the outstretched penis, and you measure the distance. If it is less than 3 centimeters, the child has micropenis, that is diagnostic of growth hormone deficiency. So as BMI can predict obesity, similarly penile length and micropenis can predict growth hormone deficiency. The baby is short and fat. Hypothyroid is dry. The newborn baby has certain features. I will tell you the features. You need to know because it's an early diagnosis that you need to do. Large baby, hypothyroid baby, like the baby of the diabetic mother, IDM. Large baby, large tongue, macroglossia. Macroglossia you get in several syndromes also. Soto syndrome, Bardet-Biedl syndrome. These are the name of the Englishmen who found out that macroglossia occurs in those syndromes. So these children all have macroglossia, that is large tongue. And this tongue falls back during breastfeeding. So what the mother will say, that my baby sleeps a lot. My baby is hardly awake. I can't breastfeed the baby. Baby is feeding for 10 minutes and sleeping for 6 hours. Baby should sleep for only 4 to 5 hours. Babies don't know the difference between day and night. Newborns don't know the difference between day and night till the 3rd month. So they often sleep in the day and they are awake at night. But this mother will say, my baby is sleeping both in the day and the night. Sleeping, excessive somnolence, sleeping too much. And whenever he is waking up, when I want to breastfeed him, he is getting a choking spell. When I try to feed him, he is getting a choking spell. Why? Because the tongue is falling back and obstructing the esophagus. Choking spell. So excessive somnolence, choking spell, dry skin of the baby, and cold intolerance. The babies are never comfortable when the AC machine is on. Never. They will shiver. Cold intolerance. Cold intolerance, dry skin, and large tongue, protruding tongue. And a face that is cretinoid. What is a cretinoid face? Cretinoid phase means you get in a bigger child, bigger hypothyroid. You have missed the baby. You have missed the baby in the newborn period. Baby is already 2 to 3 years old. Brain is not growing. So the baby is automatically blunt. That is showing in his face. He is blunt. He cannot do maths. He cannot read. He doesn't have reading skill. Mathematics skill, which appear at 5 years, it will not appear. This is a hypothyroid child. So before he gets this setback, you should diagnose it as soon after birth as possible. In America, there is a heel prick puncture. They send it for the metabolic diseases. Hundreds and hundreds of metabolic diseases immediately diagnosed. But in India, India is a poor country. Most people can't get it done, heel prick. So you have to do it clinically. And that is why the next exam is there for the 2019 batch. You have to have, theory is exempted, but you have to know the practicals. Growth hormone deficiency, which I was saying, the short penile leg, micropenis. In that you get the bone age is less than the height age, which is less than the chronological age. Bone age is less than the height age, which is less than the chronological age. All chronological age is more than the height age, more than the bone age. This is growth hormone deficiency, along with the short fat child who has a micropenis. Fat child. In frolic syndrome also you get a fat child. You get a micropenis. But frolic syndrome is a syndrome which is chromosomal defect. It is not short stature due to growth hormone. You should differentiate that. Which is frolic syndrome? There the penis is embedded in the fat. Embedded. The child is so obese that the penis is embedded in the fat. There also, if you measure from the symphysis pubis to the tip of the penis, it will be more than 3 centimeters, which occurs in growth hormone deficiency. This is one. Another is growth hormone deficiency. There are certain hormones which need to be assessed. One is IGF-1, insulin growth factor 1, and IGF-BP3. Both levels will be low. These are stimulating hormones of growth hormone. So hypothalamus is not stimulating the pituitary to secrete the growth hormone, and the growth hormone is not being secreted. So both these hormones are low. You can do it by testing it. This and growth hormone, another thing, you should give it before puberty. I told you, adolescence, most of the ossification occurs. So if growth hormone is given, you should give it before puberty. That is before 8 years in case of girls, before 9 years in case of boys. So before ossification occurs to permanent bone damage. Before that, before it fuses, before the fusion occurs, you have to give growth hormone so that the baby becomes taller. This is one thing. And the other is the upper segment and the lower segment ratio. I was mentioning it. If the upper segment is more than the lower segment, it is most probably a hypothyroid. Commonest hypothyroid. And symphysis pubis, I told you about crown rump length. Crown rump length can only be measured in sitting condition. Crown rump length. What is the crown? The tip of the skull. And what is the rump? The rump is the coccyx, which is touching the seat. That is the crown rump length. And that is the upper segment. And what is the lower segment? Lower segment is from the symphysis pubis up to the heels. That is the lower segment. That can be measured in any position, supine position or any position. But CRL cannot be measured unless and until the baby is sitting. That is one thing. And another thing, in stadiometer, measuring the height, 3 persons are required. In the stadiometer, the headpiece is flexible. So one person makes the baby stand and the headpiece touches the head. And 2 persons should see whether the heel and the buttocks are touching the stadiometer. Both the heels without the shoes. Both the heels and the buttocks should touch the stadiometer. Similarly, in infantometer, 2 persons are required. One will fix the head and there the foot piece is flexible. Picture that you are seeing now, it is measurement of the supine length of a child that is less than 2 years. Supine length is measured by an infantometer. If the infantometer is on the table, you don't have to kneel down or bend down like this. But if the infantometer is on the ground, automatically both have to kneel down. Why? Because you can see the headpiece and the footpiece. The headpiece is fixed. That is, this lady is holding the arms comfortably, holding the head of the baby straight. That is, the head of the baby is touching the headpiece. The head of the baby is touching the headpiece. Whereas this man, this measurer on his knees, is what he is doing is not only flexing the footpiece, but he is pressing down on the knees. Why? Because we know the knees in children, it is incurved. It is incurved. The legs are incurved. So in order to make it straight and measure the correct supine length, you need to make it straight. And to need to make it straight, you have to put your hands either on the knees of the baby. What he is doing is just below the knees and is pressing the footpiece. This is how we take the supine length below 2 years of age. Standing height, the headpiece is flexible and the footpiece is fixed. You can see 2 people over here, but actually we asked 3 persons to see the standing height. Why? Because this lady, whom you can see bend on her knees, she is seeing that whether the heels are touching the stadiometer. Stadiometer is the big straight measurement up behind the baby. A long stick above a standing horizontal stick, a vertical stick over a horizontal strip. And the 2 heels of the baby should touch that stadiometer. That is the 0 point. And then the 2 knees, she's putting her hands on her knees so that his or her buttocks touch the stadiometer. And simultaneously, this man, he should be standing, and he's holding the head straight. Holding the head straight means there is a line which passes through the center of the mouth to the occiput. I'm not going to complicate it. Just he has to hold the head straight with chin down, and the headpiece is flexible. It touches the head. And that is how you see the stadiometer. 3 people are required over here. 2 people are seen. 1 person is the measurer. The headpiece is firmly fixed. He's holding the chin so that the mouth is slightly open, and the chin is on the neck. You can say on the neck, little bit on the neck. And this is how you keep the position of the baby. That is the back of the head, the buttocks, back of the buttocks, and the heels, they touch the stadiometer, and that is how you get the standing height over 2 years of age. And a few syndromes also I should mention. Turner syndrome. What is Turner syndrome? Turner syndrome is a chromosomal anomaly again. It occurs more in females. Male Turners are there, but female Turners are more common. They have webbing of the neck. They have distance between the nipples is apart, and they have cubitus valgus. That is, their elbows are looking out. Elbows are looking out. That is a Turner syndrome. Turner syndrome are short in height. Down syndrome, risk of recurrence is 1%. Translocation 14-21, 21 trisomy, mosaicism, short and obese, blunt facies, hypotonia, anti-mongoloid slant of the eyes, increased epicanthal folds, hypertelorism, blunting of the nasal bridge, fat occiput, protruding and fissured tongue, ক্লিনোডাকটাইলি মানে ফিফথ ফিঙ্গারটা এরম ব্যাকা, সিমিয়ান ক্রিজ মানে এই লাইনটা পুরোপুরি যাচ্ছে, ওপরের লাইনটা পুরোপুরি থ্রু অ্যান্ড থ্রু যাবে, দ্যাট ইজ কল্ড সিমিয়ান ক্রিজ. And midline defects, that is atrioventricular canal defects, duodenal atresia, fistula, Hirschsprung's disease, strabismus, cataract. Down syndrome. Down syndrome is trisomy 21. Trisomy 21 means the 21st chromosome are 3 instead of 2. 3 or translocation 14-21. One piece of 14 is broken to go and get attached to 21 chromosome. Or a piece of 21 is deleted to go and attach to 14. 14-21 translocation or 21 trisomy, that is Down syndrome, they are also short. Down syndrome features also you should know. What is a Down syndrome? How do you diagnose a Down syndrome? And what should you tell the parents? The risk of heredity, that is in the next child, is 1%. 1%. a Down syndrome baby is usually delayed from his peers by 2 years. Down syndrome will learn reading, mathematics, calculation, everything after 2 years. That is at 7 years, not at 5 years. Reading, maths, calculation, writing. It will learn at 7 years. They love music. They may be slightly weak in mathematics. So you teach them some occupational therapy which they can do. Down syndrome need not sit in the office and earn money. Down syndrome loves music. Let the child grow up in music. Music is a beautiful thing to learn, and music is a beautiful thing which can help many children, like say cerebral palsy. Cerebral palsy, spastic children also respond to music. They love watching videos. They love watching TV. So let them watch it. There's no problem letting them watch. So similarly, in Down syndrome, you must not insist that the baby has to do a white-collar job. Not necessarily. Baby can do something by which she can earn. They love stitching. Okay, you'll teach them stitching well. Not necessarily that she sits at home and idles. She can paint. She can do something, some creative thing, some creative work she can do. She can make something. She can sell it also. She can, on cups and old cups, broken cups, she can paint and she can sell it. There's no problem. You can earn in any way you want. Earning is not necessarily a white-collar job. Most parents insist that a white-collar job is necessary for earning money. It is not so at all. Many children are more prone to learn music. Many children love dancing more. Many children are very creative. Use that creation, that creative ability to develop that baby. Down syndrome baby does not mean it's a curse on you. I know of a couple, father was working with us in Darjeeling before marriage, and he got married to a doctor from my college itself, Geetali. Geetali, I used to often accompany her. She used to get aches all over her body. I had to accompany her for her aches before her exam, often to Central Avenue. That time physiotherapy was very sparse in Kolkata. That time I'm talking about the 80s. It was very sparse in Kolkata. Only in Central Avenue you could get physiotherapy from NRS Medical College, that is from Shialda. I used to go by rickshaw with Geetali to Central Avenue for physiotherapy. Finally, she had severe rheumatoid arthritis and she expired. But she had given birth to a boy. That boy grew up and he is working in Bangalore with a white-collar job. This doctor married again and the next child was a Down syndrome, is a Down syndrome. She is already 18. She has already developed her menarche, her thelarche. All the features of SMR have already developed. But the problem is, they are not teaching her. Maybe they take her to dance school, to music school, like the rat race that we know all children are in. But they are not teaching them occupational therapy. Occupational therapy means you earn something. You earn something by your creative ability. That should be done.